Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a case discussion on a case of carcinoma of larynx, more specifically on a case of glottic carcinoma. We'll start with history, discuss each points that we have taken in history. How do we arrive at a provisional diagnosis after looking at the clinical examination and the history together? What will be a differential diagnosis and how will we manage our patient? You can also now purchase my notes. I have added links in the description. Okay, let's get started with our case. First, let me start with the history. So, Ajay, a 60-year-old male residing in Hyderabad, Hindu by religion, teacher by occupation, presented with a chief complaint of change of voice since the last 4 months. Coming to history of present illness, patient is apparently asymptomatic 4 months back when he started complaining of change of voice, which is insidious in onset, gradually progressive in nature, hoarse in nature, constant throughout the day, no aggravating or relieving factors, and associated with dry cough. Coming to negative history, although this is not a former like a proper heading under which you should write, but these are all history that you should take within the history of present illness. So there is no history of pain during speech, fever, night sweat, weakness of voice, difficulty while swallowing, pain while swallowing, difficulty in breathing, noisy breathing, foreign body sensation in throat, choking sensation or aspiration, vocal abuse, neck trauma, surgery under general anesthesia, radiation exposure, reflux disease, loss of appetite, loss of weight, swelling in the neck, chest pain, dental caries, and no history of ear or nose complaints. There is no history of similar complaints in the past or any other past history, no surgeries in the past, no known drug allergy, nothing, no significant family history. Personal history is also normal, and in addiction history, this patient is a BD smoker, 5 per day since the last 35 years, and an alcoholic, 200 ml per day for the last 30 years. So now that completes our history of the patient. Now, what do we think this case is? As we already know, this is a case of glottic carcinoma. This patient has only come with one chief complaint to you, which is change in voice. Now, does that itself only point towards glottic carcinoma? Obviously not. You could have like many other differential diagnoses from just this. So let's start discussing this point. So since our chief complaint over here is change in voice, first let's discuss what are the different causes possible that you can see in change in voice. Let's categorize them so that it is easier for us to remember. So there can be inflammatory causes like acute laryngitis, chronic laryngitis, tuberculosis of larynx. Now, chronic laryngitis is a very common cause of change in voice. Then there is neoplastic causes, which can again be divided into benign tumors and malignant tumors. Example of a benign tumor could be recurrent respiratory papillomatosis. Now, this is seen in young adults usually, and the virus responsible for this is HPV 6 and 11. And malignant tumors can be carcinoma of glottis. Then there is neurological causes like recurrent or superior laryngeal nerve palsy, Parkinson's disease, myasthenia gravis, spasmodic dysphonia. There can be functional or non-organic cause like voice abuse, psychogenic aphonia, muscle tension dysphonia. There can be traumatic causes like an external trauma, like in some kind of a road traffic accident. It can be an iatrogenic trauma as well, following intubation or following post thyroidectomy nerve injury. And it can be structural causes like Rinke's edema, vocal nodule, vocal polyp. Congenital causes like laryngomalacia, vocal cord paralysis, which is congenital, laryngeal webs. And lastly, there can be systemic or endocrine causes like hypothyroidism and acromegaly. This is a rough list of all the causes of change in voice that you could keep in mind when a patient presents to you with the chief complaint being change in voice. Now, in the change in voice, we found that the nature of the change in voice is hoarse in this case. So that will bring up the question of what are the different types of change in voice that you could possibly see and what are the different causes for each one of them. So let's start with the first one, Patient could have a husky voice. Now, husky voice happens because of the paralysis of superior laryngeal nerve, which supplies the cricothyroid muscle. This is seen in vocal fold paralysis because of superior laryngeal nerve palsy. Then, in this case, what we are seeing is a hoarse voice. Now, what is a hoarse voice? An abnormal, rough, breathy, or strained voice, and this occurs due to the disturbance of the normal mucosal wave pattern of the vocal cord. Now, various causes of hoarseness in voice could be vocal cord nodule, polyp, cysts, laryngitis, vocal cord paralysis, and laryngeal cancer. Third type is known as the hot potato voice, which is basically a muffled kind of voice which sounds like something if you put a hot potato in your mouth. The kind of voice that will come out if you try to talk at that point is known as hot potato voice. A hot potato voice occurs due to the involvement of supraglottis and base of tongue. Now, a very common example of hot potato voice, as we all know, is quinsy or peritonsillar abscess. Other than this, any supraglottic carcinoma or any carcinoma involving the base of tongue could also cause a hot potato voice. Next is a breathy voice. Now, what is the problem here? Here, the air escapes with phonation, and this gives it a very whispery quality. This is seen in unilateral vocal cord paralysis, or vocal fold bowing, or glottic incompetence. Next could be a whispering voice, which can be functional or psychological. Then there could be feeble voice. Feeble voice occurs when expiratory air is not strong enough to vibrate the vocal cords. This is a typical feature seen in tuberculosis of the larynx and even in emphysema. Next, we could have some pitch changes in the voice. There could either be a high pitched voice or a low pitched voice. Very common cause of high pitched voice is pubophonia. Now, this is a important MCQ question that you may get in your NEET PG exams. What is pubophonia? Pubophonia is when there is a persistent use of a high pitched voice by a post-pubertal male. This is important to remember that this is a post-pubertal male, despite having a structurally and hormonally normal adult larynx. That is pubophonia. And low pitched voice will be seen in cases of hypothyroidism and vocal fold thickening. Next is there could be aphonia, which is complete loss of voice. Now, this could be seen in bilateral vocal cord paralysis. It could be psychogenic or functional, and it can also be seen in advanced laryngeal cancer. Next is hypophonia. What is hypophonia? When there's an abnormally reduced volume of the voice. This can be seen in Parkinson's disease, myasthenia gravis, and vocal fold atrophy. Next is hypernasality of the voice, which is very commonly known as rhinolalia aperta, where there is an excessive nasal resonance during speech. This is seen in problems with palate, when there is cleft palate or velopharyngeal insufficiency. Other opposite of this is hyponasality, which is also known as rhinolalia clausa. Here we have a decreased nasal resonance during speech. Common examples of this could be in a nasal obstruction like in polyps or adenoids or in allergic rhinitis. Lastly, we could have a strained or pressed voice. Here we find excessive tension in the voice, which is often very tight and effortful. Common examples of this is seen in muscle tension dysphonia and spasmodic dysphonia. So these are all the different types of change in voice that you could see. In our case, we have seen a hoarse type of voice. So we can see a differential diagnosis. Some of the causes are already over here. Next, let's move on to the next feature. Before that, let's talk about, say a patient comes to you with a change in voice. Would you be worried for each case? Or when would you think to worry more and do more a complete otolaryngological examination? So, any history of change in voice which has been persisting for more than 3 weeks, it is important to remember this time frame. More than 3 weeks, they should all undergo a complete laryngoscopic evaluation to rule out serious causes like a case of malignancy of larynx. So, it is important to remember whenever it is more than 3 weeks, this is this is a time when you have to be more aware that this could possibly be something else, something more serious like malignancy. Now we're talking about hoarseness of voice. Now, how do you define hoarseness of voice? Hoarseness of voice is a harsh, discordant voice which is not characteristic of the patient's age, sex, or character. This can either refer to altered voice quality or voice pitch or volume resulting from pathology of the vocal cords or the neuromuscular control. Next, let's talk about if a patient presents to you with hoarseness of voice, what are some danger signs you should be looking out for? So there are a lot of them. We'll be seeing a lot of associated complaint or history along with hoarseness of voice. So first of all, as we discussed, whenever there's a change in voice or hoarseness of voice more than 3 weeks, it may indicate towards malignancy, vocal cord paralysis, or chronic inflammation. Next, whenever there's a associated dysphagia or odynophagia, this can be suggestive of a tumor which is involving adjacent structures. Next, associated neck mass. This could be a possible metastatic lymph node from a case of laryngeal cancer. Any history of weight loss or other systemic symptoms should also raise the suspicion of malignancy or other systemic diseases like other granulomatous diseases of larynx. Any case of associated aspiration, which means there could be a nerve involvement over here. Next, any associated stridor or respiratory distress, which can indicate an upper airway obstruction. Next is an associated hemoptysis, which could be indicator of a possible malignancy or granulomatous disease. Any associated unilateral ear pain in a case of hoarseness of voice. Usually, it is a case of referred otalgia over here, where there is pain in the ear without any pathology in the ear. This can often occur due to the vagus or the glossopharyngeal nerve involvement in a glottic or supraglottic tumor. Another danger sign is a history of smoking or alcohol use in the patient because both of them are major factors of laryngeal cancer. In later part of the case presentation, I'll discuss how smoking and alcohol, what is the mechanism of action of it to cause the laryngeal cancer. Other than this, other danger signs could be a history of prior head and neck radiation, which increases the risk of secondary malignancy or radiation fibrosis. Lastly, voice fatigue or breathiness is also a danger sign in hoarseness of voice. So, these are all the different danger signs you should remember when a patient comes to you with hoarseness of voice. Next feature in the history that we took was that the hoarseness or the change in voice was constant throughout the day. That means there could be some diurnal variations we see in certain diseases. So, what are these diurnal variations that we can see? And what are some examples of it? And what is the explanation behind it? So, what is a disease where the change in voice worsens as the day passes? Very common example is myasthenia gravis, where the voice keeps worsening as the day passes because of vocal fatigue. Second, could be a case of vocal nodule or vocal polyp, where as the day passes, you end up overusing your voice, so it keeps worsening. So these are the two diseases that where you can see the voice worsening as the day passes. Next is what is a disease where the voice improves as the day passes? That is a case of Rinke's edema. Why? The reasons are first of all, when patient is upright and they're speaking during the day, the fluid redistributes due to the gravity. And this ends up reducing the edema very slightly. And hence, because the edema is reduced, it improves vocal cord vibration. Second, phonation during the day helps in mobilizing and redistributing this edema. So it also leads to better chord approximation and improved voice quality. Third, there is also improved circulation as the day passes. So all of these together, this warming up effect of speaking throughout the day and improved circulation, all of this allow for a better vibration leading to better voice in case of Rinke's edema. Next is what is a disease where the change in voice is worst in the morning, and that is chronic laryngitis. Why does that happen? First of all, when you're lying down during sleep, that leads to fluid redistribution and increased vascular congestion of the vocal cords. This leads to more edema as you get up in the morning. Second is, overnight there is a decreased clearance of mucus. This is the second reason. As there is a decreased clearance of mucus, more mucus collects on the vocal folds and it starts interfering with its vibration and leads to a rough, hoarse voice. Third reason is because of the decreased swallowing at night, the salivary and mucus clearance mechanisms are reduced during sleep, which leads to more residual secretion in the larynx. So these are the reasons why the voice is the worst when you wake up in the morning in case of chronic laryngitis. And very often, the history that the patient will be giving to you is they'll say that my voice improves as the day goes on in chronic laryngitis. This is because of these three reasons. Next question is, what is a disease where the voice is worst in the evening? This could be seen in malignancy, even in vocal cord palsy. So, what happens in malignancy is the tumor involvement of the vocal cord, it reduces the mobility and efficiency of the vocal cord. With continuous use throughout the day, the vocal cords start getting tired faster, leading to worsening of the voice. And now, this tumor can also cause inflammation and lymphatic obstruction, resulting in edema of the vocal cord, which in itself causes uh, causes worsening of the change in voice. And lastly, muscle compensation fails. So early in the day, the compensatory muscles, which are in the false vocal cords and supraglottic structure, they may help in supporting phonation. But as the day passes with fatigue and overuse of the vocal cords, these compensatory mechanisms start to weaken down, leading to a poorer quality during the day. So that's all about the diurnal variation of the change in voice that we see in different conditions. Now let's talk about all the negative history that I've mentioned here. Why is each one of these important? And in case each one of them were present, what would it indicate? So first, let's start with pain during speech. Now, pain during speech, what does it indicate? It can indicate infiltration beyond the layer of mucosa into the deeper tissue like intrinsic laryngeal muscles, perichondrium, or cartilage, or nerves. This usually will suggest the presence of an advanced disease. And secondly, it can also be because of a superimposed secondary infection in the setting of malignancy. So either this could indicate an infiltration, deeper infiltration, or second, it can suggest a secondary infection. Now let's also look at what are the different causes of pain during speech. So there can be inflammatory causes like acute laryngitis, chronic laryngitis, vocal fold granuloma, or ulcer. There can be neoplastic causes like laryngeal carcinoma, benign tumors with ulceration or secondary infection. There can be traumatic causes like vocal fold hemorrhage or trauma, intubation related injury or surgery related injury. Neurological causes like superior laryngeal nerve involvement, or there can even be referred pain from the ear or pharynx. Next, there can be a muscle strain or overuse, for example, in muscle tension dysphonia or vocal fatigue. Lastly, there can be some infectious causes of pain during speech, like laryngeal tuberculosis. This is a very important feature that we see in laryngeal tuberculosis. Other than that, there could also be deep neck space infections affecting the larynx. So, this is about pain during speech. Next is fever and night sweats. Now, if fever and night sweats was a part of the history, it could possibly indicate some systemic disease like TB of the larynx or HIV or malignancies. There could be a secondary infection or a superimposed inflammation. It could also be showing a possibility of having distant metastasis, which is quite rare. So, these are the three things that you can find out by getting a history of fever and night sweat. Next is weakness of voice. This is a very important feature. It is the earliest symptom that you see in a case of tuberculosis of larynx. Other than that, it is also seen in recurrent and superior laryngeal nerve palsy or in case of muscle tension dysphonia. Next is difficulty in swallowing or dysphagia. The presence of this could indicate in this case there can be a supraglottic involvement. So, in a case of glottic cancer, usually we do not see difficulty in swallowing unless there has been further spread, whereas this is more common complaint in case of a supraglottic tumor or in a case of hypopharyngeal malignancy. Next, the dysphagia will also talk about determine the tumor extent. The dysphagia will suggest the extension of the tumor beyond the larynx, possibly involving the pharynx, esophagus, or pre-epiglottic space. So basically, we find out this could be an advanced stage of the disease because of the presence of dysphagia. Lastly, this will also help you in finding out the prognostic value. So, presence of dysphagia may be associated with a poorer prognosis because of the tumor being larger or more infiltrative. Next is pain while swallowing, also known as odynophagia. What will odynophagia indicate? It can indicate the involvement beyond the glottis, such as if it involves the supraglottic region or the pharyngeal wall or the preepiglottic space, we usually see complaint of odynophagia. Other than this, it could also involve a spread to the sensory nerve rich areas like the internal branch of superior laryngeal nerve. It could also point towards ulceration or infiltration. It can help you in differentiating the site of origin because this is a more common complaint in case of a supraglottic carcinoma. And it can also indicate a secondary infection or inflammation. Next, if this patient had complained of difficulty in breathing, that would have indicated a lesion which is in the glottic chink and obstructing the airway. Other than this, it could also be because of some lung metastasis or aspiration pneumonia, tuberculosis, even COPD. Next, negative history is about noisy breathing. Noisy breathing usually indicates a airway compromise, and it can also help you in localizing the tumor because you can see an inspiratory stridor in case of a supraglottic or a glottic lesion, expiratory stridor, which suggests a lower airway involvement. This is less common in a case of larynxia. And a biphasic stridor will be seen if there is a glottic or a subglottic lesion. So that's the importance of a history of noisy breathing. Next is a foreign body sensation in the throat. Now, this is a very important complaint because it is the earliest complaint that you can see in a case of supraglottic carcinoma. Whenever there is a persistent foreign body sensation, especially in a case of smoker or an alcoholic, it should raise the suspicion for malignancy over benign causes like pharyngitis or reflux. Next is a history of choking sensation or aspiration. This can indicate a supraglottic involvement where there is an impairment of the protective reflexes. Second, it can also suggest a compromise of airway protection. And lastly, it can suggest an invasion or compression of either the recurrent or the superior laryngeal nerve. Next negative history is a history of vocal abuse. A vocal abuse, especially in a profession where the voice is very important, for example, in singers, in teachers, etc. So, in these people, vocal abuse history would be very important to take because that would point towards diagnosis of vocal nodule, vocal polyp, Rinke's edema, because these are all diseases that are commonly seen because of the result of vocal abuse. Next, taking the history of neck trauma is important because in neck trauma, there can be a recurrent laryngeal nerve injury, there can be laryngeal fractures, there can be an arytenoid dislocation and cricoarytenoid joint injury, and all of these can be causing a hoarseness of voice. So it is important to rule out neck trauma as a cause over here. Next is a history of surgery under general anesthesia. That will help you in ruling out a case of intubation granuloma because of when you try to intubate the patient, that can cause a result in injury to the patient, and intubation granuloma can be also a differential diagnosis over here based on the history. Next is a history of radiation exposure. Now, radiation exposure history, the most common malignancy that occurs because of this is thyroid malignancies. Next, let's talk about reflux disease. Now, why is the history of reflux disease important? What all history do you take in this case? So there will be a history of nocturnal cough, heartburn, regurgitation. Now, why do we take this? Now, what happens here is acid reflux can irritate the laryngeal mucosa and vocal fold. So this can lead to actually chronic inflammation, leading to hoarseness or change in voice. So you may see a change in voice even in a case of reflux disease. So a GERD related voice change can actually end up mimicking laryngitis, vocal nodule, or even early cases of malignancy. So it is important to take the history of reflux disease over here as well. Next is a history of loss of appetite and loss of weight. These are like such constitutional symptoms which can indicate towards a case of malignancy or a tuberculosis, or it can also indicate granulomatous diseases like vaginous granulomatosis, for example. Next is a history of swelling in the neck. Now, in a case of change in voice, a history of swelling in the neck will actually indicate towards a lymph node metastasis. And whenever there's a lymph node metastasis, that indicates towards a more advanced stage of the disease. Next is a history of chest pain. Now, this is important to rule out any other cardiac cause or GERD. Next is a history of dental caries. Now, why is history of dental caries important in a case of carcinoma of larynx? In case in the treatment plan, if you end up mm, telling the patient that the treatment plan would be radiotherapy, in that case, it is important to find out about dental caries because in radiotherapy, the patient may end up having osteoradionecrosis of the mandible and maxilla if they have a caries tooth present and which gets missed. Or if you are planning for a surgery in the patient, in that case the dental caries can act as a septic foci. So treatment of the dental caries is very important before you start primary treatment of the carcinoma of larynx. So these are the two very important factors in relation to dental caries over here. Next is a ear pain. Now, referred otalgia, what we see here, why is referred otalgia important? Because first of all, in a cancer of the involving the glottis, this can be an early clue indicating a deeper spread of the disease, meaning it is an advanced disease. Second, sometimes this referred otalgia may precede all other symptoms like voice change or dysphagia. Lastly, this is important in non smokers or any atypical presentations. The referotalgia is also seen in cancer of the piriform sinus, especially in early stage disease. So, it is very important that you take your history as well. Just because it is a case of change in voice, you should not be ignoring the other parts of the ENT. So that's all about the negative history and what is the importance of each of those points that we have discussed. Next, let's talk about what is why is family history important, and we'll talk a little bit about the addiction history. So first of all, in family history, the things we should be asking about is whether there is any history of tuberculosis or malignancy in the family. That is what is relevant over here. Next is let's talk about addiction history. So, first of all, at what point, when you're taking the history, do you call a person to be alcoholic? So, there are three features over here. First of all, is that the person consumes alcohol almost every day. Second is they consume alcohol even when they are alone. And third is the amount, which is more than 90 ml per day. Next, coming to smoking. Now, how when you talk about smoking, you need to know something known as pack year. What is pack year? Pack year is the number that you get when you multiply the number of packs of cigarettes smoked per day by the number of years that the person has smoked. For example, one pack year will be equal to smoking 20 cigarettes per day for 1 year. So basically, one pack is equal to 20 cigarettes. That's how you calculate pack year. Next, let's talk about what are the carcinogens that we see in smoking and alcohol. So, in smoking, the carcinogens that are present in tobacco are polycyclic aromatic hydrocarbons. Example is benzopyrenenes, heterocyclic aromatic amines, aromatic amines and aldehydes, and N-nitrosamines, for example, N-nitrosodiethylamine. These are the common carcinogens that we get in tobacco. Now, what are the carcinogens in alcohol? So that will vary different. It will be it will be different in different alcoholic beverages that you have. For example, in here the carcinogen is nitrosodimethylamine. In wines, it is tannin. In dark liquors like whiskey and rum, they'll have greater content of organic compounds like esters and acetaldehyde, which act as carcinogens compared to the light liquors like vodka and gin. So this is a very common Viva question that you get if you get a case of any kind of malignancy. So it is very important to know what are the carcinogens in tobacco as well as alcohol. Next, we need to know about what is the mechanism of action of carcinogenesis in case of tobacco as well as alcohol. So, tobacco, the mechanism of action is that it causes a global hypomethylation and hyperacetylation of DNA. Once the carcinogens in tobacco get absorbed, they require activation by cellular enzymes belonging to the cytochrome P450 group. This is required to promote tumorigenesis and their effects by detoxifying enzymes. Now, dysfunction of these different enzymatic pathways have been seen to be associated with an increased risk of head and neck squamous cell carcinoma. Very important factor to remember here is not only smoking and alcohol, they're independent risk factors for malignancy, but they also have a synergistic action together. So, what happens is, along with alcohol, if you're also smoking, there will be a synergistic action because of the increased mucosal absorption of these same carcinogens because of the result of increased solubility of these carcinogens in the alcohol. So, it's basically not 1 plus 1 equal to 2, but rather 1 plus 1 equal to 3 over here. So, they both act together and they have a synergistic action of carcinogenesis together. So this is the mechanism of action of tobacco. Next, let's talk about what is the mechanism of action of alcohol. So in chronic alcohol use, it upregulates enzyme of the cytochrome P450 system, which results in the activation of procarcinogens into carcinogens. The immediate metabolite that is formed when ethanol is acetaldehyde. This acetaldehyde is then inactivated by conversion to acetate by acetaldehyde dehydrogenase. So this acetaldehyde that we have talked about, this immediate metabolite, this is the one which exerts its carcinogenic effect by directly binding to DNA. It also alters methyl transfer and therefore it results in genetic hypomethylation, which in turn will affect the transcription of multiple genes. In addition, reactive oxygen species are also generated during the metabolism of alcohol, which can have its own mutagenic effects. So these are two things that happens in alcohol due to acetaldehyde, which is a metabolite of ethanol. Secondly, alcohol can also decrease the activity of DNA repair enzymes, leading to more chromosomal damage. So these are the different ways by which alcohol induces its carcinogenic effect. Now let's talk about, since we are talking about malignancy of the larynx, there are three regions, the supraglottis, glottis and subglottis. Now, if a growth happens in each one of them, how would each one of them present? Let's first know about the features. What are some complaints? What are some symptoms you'd be seeing? So in case of supraglottic growth, the earliest symptom can be a foreign body sensation of throat and a case of constant throat clearing. And these patients are more likely to have dysphagia or dinophagia and a muffled voice, also known as a hot potato voice. Neck mass is very common in case of supraglottic growth because of the rich lymphatic drainage and early lymphatic spread that happens here. And another important feature here is the case of referred otalgia by 9th and 10th cranial nerve. And lastly, hoarseness of voice is a very late symptom in case of a supraglottic growth. Usually in supraglottic growth, the voice is preserved for a long time since cords are usually not involved. Next is, let's talk about what is the presentation of a glottic growth. The earliest and the most prominent symptom that we'll see is a change in voice. Then the maximum phonation time will reduce over time. So basically, the period of time during which you are able to talk without feeling any fatigue, that will start reducing over a period of time. And this growth can either be exophytic or infiltrative. Exophytic tumors usually end up involving the rima glottitis, and it leads to difficulty in breathing and noisy breathing. And infiltrative tumors usually cause deeper infiltration, which leads to vocal cord fixity, aspiration, and difficulty in breathing. Because there is more irritation of the larynx here, so here you'll also see cough being a common complaint. Other than this, stridor is a feature if bilateral vocal cord involvement has been seen. And very, very important to remember here is usually no neck mass is seen in the early stage because of the poor lymphatic drainage of the glottic region. Usually, in case neck nodes are seen, it is seen more in the later stages, in the advanced stages of the disease. So, these are the features of a glottic carcinoma. Next, let's talk about a subglottic growth. A subglottis region is a very rare location for a malignancy to occur, so it's often ends up being diagnosed very late because a lot of the cases are very asymptomatic early. They do not have any specific symptoms. But if they do have symptoms, the very common symptom would be stridor or breathing difficulty because of the narrowed subglottic space. So it leads to an early airway compromise. Next, they can also have cough or hemoptysis. Hoarseness can also be a feature if it extends superiorly to involve the cords. And lastly is the presence of a neck mass, but again, which is seen only in cases of advanced carcinomas. So these are different features that you see in the three different sites of the larynx if there is a malignancy involving these regions. So if we had to summarize, in a supraglottic tumor, more commonly we see painful swallowing, neck mass, and referotalgia. Glottic tumor will have more of a persistent hoarseness more than 3 weeks. Neck mass is not a feature in the early stages. And a subglottic tumor will have stridor, dyspnea, and very minimal early symptoms. A very important clinical tip to remember is if there is a case of unexplained otalgia, but with a normal ear, meaning it is a case of probably referred otalgia, in that case, definitely examine the supraglottis and the hypopharynx because malignancies involving these two regions usually end up having the history of referred otalgia. This is very, very important. Now let's move into the general examination. We have discussed all of the history points that we have seen so far. Now we'll discuss what are the findings that we have seen in this patient. So general examination is normal and systemic examination is normal. So I'm just moving ahead. Oral cavity and oropharynx examination is also normal. I'm going to move ahead. Only in case of teeth, there has been some nicotine stains. Now coming to indirect laryngoscopy findings, I'll talk only about the positive finding here. In the right true vocal cord, we see a pinkish proliferative growth involving the posterior two-thirds of the right vocal cord. Surface is irregular, vocal cord is mobile, anterior commissure is not involved, and growth is moving along with the vocal cord side to side. Glottic chink is adequate. So this is the positive finding that we have seen in our indirect laryngoscopy. Neck examination is normal where laryngeal crepitus is present and we have not found any neck nodes. And nose, paranasal sinus and ear examination is normal. So now let's discuss a positive finding over here. So first of all, the indirect laryngoscopy finding that we have seen, the pinkish proliferative growth, posterior two-thirds of the vocal cord, irregular surface. These are all features which is indicating towards malignancy. Here we see that the vocal cord is not fixed, it is mobile, and the glottic chink is adequate, and the anterior commissure has not been involved. These are all important features that we have noted here. This will help us in staging the disease later on. So, talking about indirect laryngoscopy, what are some hidden areas in the larynx that we are not able to see when we perform an indirect laryngoscopy? These are lingual surface of the epiglottis, anterior commissure, subglottis, undersurface of the vocal cord, ventricles, postcricoid area, and piriform fossa apex. All of these areas are actually very difficult to see on indirect laryngoscopy. So in that case, how should you see these areas if you suspect especially in case like this where you suspect malignancy. In that case, you should actually perform a direct laryngoscopy under general anesthesia. That is actually the gold standard test that will help you in viewing all of these areas properly. Next, if we had to draw and represent, that is also something you need to know how to draw a indirect laryngoscopy diagram. I have a separate video where I totally discuss and describe how to draw this indirect laryngoscopy findings in a diagram. Moving on, we were talking about that in our case we have seen that the vocal cord is mobile. And a very important thing is also to know what is a fixed vocal cord. So there are two terms over here. One is a fixed vocal cord and one is fixed hemilarynx. What is the difference between both of them? Now, a vocal cord is said to be fixed when there is no movement of the vocal cord on attempted phonation or respiration, meaning there is a complete paralysis or immobility of the vocal cord. When you perform indirect laryngoscopy or fiber optic laryngoscopy, the vocal cord will show no abduction on deep inspiration and it will show no adduction on phonation, and it remains only in one position throughout. Most often it is seen to be in a paramedian position. So this is what is a fixed vocal cord. Next, let's talk about what is a fixed hemilarynx and how is that different from a fixed vocal cord. So, a fixed hemilarynx means that not only the vocal cord is involved, but the entire half of the larynx has lost mobility, and this ends up indicating an extensive tumor infiltration. So, the structures involved here is the vocal cord, false cord, arytenoid, and cricoarytenoid joint. These are all the structures that is fixed in a case of fixed hemilarynx. Fixed hemilarynx is actually a marker of an advanced disease because that suggests basically that there has been deeper infiltration of the tumor. This will impact the prognosis of the patient and your surgical options. Cord fixation alone, you can actually perform partial laryngectomy, but if there is a hemilarynx fixation, it often ends up requiring total laryngectomy. So these are the differences between a fixed vocal cord and a fixed hemilarynx. Now, we're talking about fixed vocal cord. What are some different ways that the vocal cord can actually become immobile? Number one is when there because of the presence of the bulk of the tumor, which can kind of put a pressure effect on the vocal cords. Second is invasion of intrinsic laryngeal muscle, most commonly the posterior cricoarytenoid, which leads to the loss of abduction, and this makes the cord appear fixed. Third is when there is an infiltration of vocalis or thyroarytenoid muscle, and this can cause in restricted mobility or partial fixation of the vocal cord. Next is fourth, an involvement or fixation of the cricoarytenoid joint. Where here we see a true cord fixation with no movement at all during phonation or inspiration. Fifth is an involvement of the recurrent laryngeal nerve, which is more rare usually and seen in more advanced cases. Sixth is the involvement of paraglottic space, which leads to restricted movement, and this can often end up preceding joint fixation. And last reason, the seventh reason is a cricoid or thyroid cartilage invasion, which results in a fixed hemilarynx in advanced cases. So these are the 7 reasons how a vocal cord fixation can happen in a case of laryngeal cancer. Next, a very, very important Viva question is what are the differences between vocal cord paralysis and vocal cord fixity? Starting with what is vocal cord paralysis? So, vocal cord paralysis is when we see a loss of vocal cord movement due to nerve damage, whereas vocal cord fixity is a loss of movement because of a mechanical obstruction, infiltration, or a joint fixation. Second, usual causes in case of vocal cord paralysis is neurological, most commonly the recurrent laryngeal nerve, which can be because of surgery, tumor, or it can also be idiopathic. Whereas vocal cord fixity cause is usually a mechanical or structural cause where there is tumor infiltration of the muscle, joint, or cartilage. Next is the position and appearance of cord. In case of vocal fold paralysis, the cords appear to be at a lower level than the opposite side, which is normal. There can be a bowing of the cord and a wavy appearance, and the cord appears to look shorter and thicker, whereas the vocal cord looks completely normal in case of a fixed vocal cord case. Next is on performing the probe test, we see that the cricoarytenoid joint is mobile in vocal cord paralysis and it is fixed in case of fixed vocal cord. Arytenoid subluxation is rare in vocal cord paralysis, but it can happen secondary to muscle imbalance. Arytenoid subluxation is more likely to be seen in case of a fixed vocal cord because of joint or structural damage. Next is flickering movement of the cord is present in case of vocal cord paralysis but absent in case of vocal cord fixity. Next, when you perform stroboscopy, if you look at the mucosal wave pattern, it is often preserved if the muscle bulk is intact in case of vocal cord paralysis. But this mucosal wave is absent in a case of vocal cord fixity. Here, the mucosa will look very stiff or tethered. Last of all is reversibility. Vocal cord paralysis may improve if the nerve injury recovers, but vocal cord fixity is a very irreversible condition unless it has been surgically released. For example, joint ankylosis. So these are all the differences between vocal cord paralysis and vocal cord fixity. And it's a very, very important Viva question that you'll 100% be asked about if you have gotten a case of malignancy of the larynx. Next is again a very important question. What is a transglottic growth? Now, transglottic tumor is basically a tumor which has involved the glottis and then it has either extended both above into the supraglottis or below into the subglottis. So basically, it's a tumor that has involved more than one subsite in the larynx. A true primary transglottic tumor is said to originate in the laryngeal ventricle. And a very important point to remember here is whenever a transglottic tumor is present, it is at least a stage T3 at presentation. Why? Because of the vocal cord fixation, which happens because of the involvement of the cricoarytenoid joint or the recurrent laryngeal nerve. So because of this, when we'll talk about the TNM staging, we'll know more why I'm saying it's T3. But for now, remember that whenever there's a transglottic growth, it is at least T3 in presentation, which means it is a much more advanced disease and more likely to require total laryngectomy. Now, how do usually tumors become transglottic? There are 4 ways by which that happens. First is by crossing the ventricle directly. Second is by crossing at the anterior commissure. Third is by spreading through the paraglottic space. And fourth is by spreading along the arytenoid cartilage posterior to the ventricle. So these are the different ways how a tumor that has begun in the glottis can end up becoming a transglottic tumor. Next, we have seen on neck examination. Let's discuss a few Viva questions in relation to this. So you have seen a laryngeal crepitus being present here. So that brings us to the question, what is laryngeal crepitus? If you see in the image over here, if in a normal case, when you move the larynx from side to side, it will produce a very grating or crepitant sound. This sound happens why? This is because of the movement of the cricoid cartilage over the vertebral bodies. This is known as laryngeal crepitus. Now, when the laryngeal crepitus is absent, what does it indicate? First of all, it can either be physiological or it can be pathological. When it is physiological, it is seen in usually neonates and children due to unossified cartilages in them. Therefore, you're not able to elicit crepitus when you move the larynx from side to side. When this is pathological, meaning laryngeal crepitus is absent pathologically, this is a sign which is known as the Boca's sign. Boca's sign refers to the absence of laryngeal crepitus. Where do you see this? This usually happens when there is a loss of the retropharyngeal space, which can be seen in a case of postcricoid carcinoma because of infiltration. It can be seen in prevertebral abscess because of soft tissue collection pushing the larynx forward. It can also be seen in retropharyngeal lymphadenopathy or tumors. It can also be seen in port spine where there is a tubercular cervical spine involvement. So this is Boca's sign. So now let's summarize our case and then we'll talk about our diagnosis and management of the case. So a 60-year-old male was brought to OPD with a complaint of change in voice since 4 months. This change in voice is insidious in onset, gradually progressive in nature, hoarse in nature, constant throughout the day, no aggravating or relieving factor, and associated with dry cough. Also, forgot to mention over here that the patient is a smoker and an alcoholic. On examination, there is a pinkish proliferative growth seen involving posterior two-thirds of the right vocal cord, surface irregular, vocal cord mobile, anterior commissure not involved. Growth is moving along with vocal cord side to side. Glottic chink is adequate. So that's our summary of this case. So this is our summary now. Let's talk about what is our provisional diagnosis. So our provisional diagnosis at this point is malignancy of larynx, subside glottis, and clinical staging is T1A N0MX stage 1. Now, this is very important to know how to write this. You cannot just say this is a glottic carcinoma or things like that. There is a particular way, the forma that you should follow. So you cannot say squamous cell carcinoma over here of the glottis because you haven't actually tested histopathologically. So your provisional diagnosis is that you are suspecting a malignancy in the larynx and you think it is most likely in the glottis, which is why the subsite is glottis. And then you have to stage the disease according to what the findings that you have found. So I'll discuss the TNM staging of glottic malignancy later on, but roughly we have said T1A because only one vocal cord is involved and there is no impaired vocal cord mobility. N0 because we have not found any neck nodes. MX because we have actually not assessed the patient for presence of metastasis. And all of this falls under stage 1. Okay, next question here would be, how do you support your diagnosis? What are the points in favor for your diagnosis? Just starting right from history. First of all, this is an elderly 60 years old male. So the age group and the gender both favor malignancy. Next is a change of voice for 4 months. So we have noted that there is a progressive hoarseness, and we have learned already before that progressive hoarseness is actually a danger sign when a patient comes to you with hoarseness. On top of that, this is a very short duration of symptomology, which is basically very indicative of malignancies. Then, according to habits, the person is a chronic smoker and alcoholic, which are both like huge risk factors, not only individually but even together synergistically, they are risk factors for the development of malignancy. And lastly, when we examined, we found a pinkish proliferative growth. Proliferative growth is one of the points that is important, and we have seen that this growth has an irregular surface. So all of these points together, they favor our diagnosis of malignancy of larynx. Now let's talk about what are the possible differential diagnoses and why are we considering them a differential diagnosis, and what is the reason they are not our provisional diagnosis. What are the points which is not in favor of them being the provisional diagnosis. So we have solitary papilloma of larynx, vaginous granulomatosis, tuberculosis, leprosy, syphilis, vocal polyp, Rinke's edema, vocal nodule, and chronic laryngitis. We'll discuss each one of them now. So first starting with solitary papilloma. Now this is a most common benign laryngeal tumor. This is a MCQ question that you can get in your NEET PG. So the reason why we considered this is because this can actually present as a pinkish exophytic irregular growth on the vocal cords. However, the points which is not in favor is we usually see this in younger adults, not in elderly age group. Second is solitary papilloma more commonly involves the anterior part of the vocal cord, whereas here we have seen the growth is involving the posterior part. Next is vaginous granulomatosis. Now, vaginous can involve the subglottic region and the larynx, causing hoarseness or airway obstruction. So, that is a differential diagnosis over here because it can cause hoarseness. However, the reason why we have not considered is because vaginous typically involves multiple systems. Like it can involve the nose causing nasal crusting epistaxis, involves the sinuses causing sinusitis, and even have renal involvement. So it is not only limited specifically to the larynx, specifically in the glottic region. So usually even if larynx is involved, we usually see subglottic stenosis rather than an isolated glottic mass. And this is also not associated with proliferative masses mimicking malignancy in glottis. So these are the reasons why vaginous granulomatosis gets ruled out. Next is TB laryngitis. Now TB is not a part of this because there's a lot of symptoms that we do not have here, like weight loss or fever, night sweats, or any positive history of cough with sputum. And before that, let's also talk about what are the typical features that you get in TB laryngitis. Now, TB laryngitis, the earliest symptom I have mentioned before, is weakness of voice and also odynophagia. So, a combination of these two symptoms should make you suspect the presence of TB laryngitis. And the first sign that we see is a hyperemia of the vocal cord. There is also a typical appearance of vocal cord which you see in the first image over here, which is a mouse nibbled appearance of the vocal cord. Other than this, in the interarytenoid region, you'll see a mammillated appearance, and there can be granulation tissue in this region. And the epiglottis also has a typical appearance which is known as turban epiglottis, if you see in the second image over here, where we find a pseudoedema of the epiglottis. Other than this, there's a pale mucosa all over, and you can also find coexisting pulmonary TB. So these are all the features of tuberculosis of the larynx. Now, a very important question here is that tuberculosis usually involves the posterior part of the larynx. Now, why is that? That is because when you cough sputum from the lungs, it is usually coughed out along the posterior wall, and then this results in a stasis of stasis of sputum over the arytenoids and the interarytenoid region. And that is why the posterior part of the larynx is the most common site to be involved in a case of TB larynx. Okay, moving on to our next differential diagnosis, which is leprosy. Now, the reason we have considered is in advanced lepromatous leprosy, it can involve the larynx, causing hoarseness, thickening of epiglottis, arroepiglottic folds, and true cords. However, the reason why this gets ruled out is it is very rare to see isolated laryngeal leprosy without any other cutaneous or nasal involvement. So, in this case, we have not found any cutaneous lesions or nasal stuffiness or any sensory loss. And even if lesions do appear, there is typically a diffuse thickening rather than a proliferative mass. And progression is much slower than what we have seen over here, where in case of malignancy, you have a very short duration of symptoms. Next differential is syphilis. Now, laryngeal syphilis can present with masses, ulcers, gummatous lesions leading to the development of hoarseness. However, syphilitic lesions are often ulcerative or destructive. Typically, they are not the proliferative mass that we have seen in our case. And also in this patient, we do not have a history of other syphilitic symptoms like rash, genital ulcers, neurological signs. This is very rare in modern clinical settings to have an isolated laryngeal involvement in a case of syphilis. So we should definitely consider syphilis if there are certain history features over here, if there is a multiple site of involvement, there is a history of high risk behavior, or any other systemic features present. Next differential is a case of vocal polyp. Now, this is a benign lesion which is commonly seen in smokers causing hoarseness of voice. So, that is our patient definitely who is a smoker and has presented with hoarseness of voice. But the reason why this does not work is vocal polyp, the major cause behind is a presence of vocal abuse, which is not, even though our patient is a teacher, we have not gotten any history of vocal abuse. Secondly, polyps usually look very smooth and pedunculated or sessile. They do not look like a proliferative irregular mass. And other point is vocal polyp most commonly involves the anterior part of the vocal cord, and it is very rare in the posterior two-thirds of the cord, which in our case we have seen a growth in the posterior two-third of the cord. And vocal polyp is usually unilateral but not associated with dry cough. Next differential is Rinke's edema. Again, this is a disease which is commonly seen in smokers and it can cause hoarseness of the voice. Typically, however, Rinke's edema is a bilateral case where we see a gelatinous translucent swelling over the vocal cords. It is not a proliferative growth. And it also does not have an irregular surface or any dry cough presentation. And usually it involves the entire cord and not just the posterior two-third. This is why this is not a case of Rinke's edema as well. Next is vocal nodule. Now, vocal nodule, the reason why we are considering is that this is again a benign lesion which can cause hoarseness of voice. But the reason why we are not considering this as a provisional diagnosis because usually vocal nodules are bilateral and symmetrical and seen at the junction of anterior one-third and posterior two-third. Usually they do not have pinkish proliferative irregular growths, and usually it is seen in younger individuals with a professional who are professional voice users and with a history of vocal abuse. Our last differential here is a case of chronic laryngitis. Now, smokers are actually prone to chronic inflammation, so this could be a possible differential for our case. But the presentation of chronic laryngitis is usually a diffuse erythema and edema. There is usually no mass or proliferative growth seen. Hoarseness may be seen, but it is not progressive and it does not have a discrete mass like in our case. So these are all the differential diagnoses that you need to know about and why we are considering them, and at the same time why they are not our provisional diagnosis. Now let's talk about a little bit about carcinoma of larynx. We have already spoken about the presentation of larynx. Here we will talk about the different subsites of CA larynx, and we'll also talk about what is a growth pattern, what is a spread pattern in case of CA larynx of different subsites. So the most common site of CA larynx is the glottis, where we see 60% cases. Supraglottis larynx gets involved in 35% cases and the subglottis gets involved in 5% cases. So this is again a very important MCQ that you get in your NEET PG exams. Also a very common Viva question that you are asked. Now let's talk about what are the different subsites of larynx. So we have supraglottis, glottis and subglottis. Within supraglottis, we have suprahyoid and infrahyoid glottis, both its lingual and laryngeal surfaces. We have the array-epiglottic folds, arytenoids, vestibular folds and laryngeal ventricles. Within glottis, we have the true vocal cords, anterior commissure and posterior commissure. And subglottis, it starts 10 mm below the free margin of the vocal cord and it extends to the inferior edge of the cricoid cartilage. So these are our subsite of the larynx. Now let's talk about what is the carcinoma spread pattern in each of this. So let's first talk about supraglottic CA. So this will have a local spread, lymphatic spread and hematogenous spread. Now for local spreads, a supraglottic CA first can spread within the supraglottis to involve the epiglottis, array-epiglottic folds, the false vocal cords, pre-epiglottic space and the laryngeal ventricles. Anteriorly, it can involve the pre-epiglottic space. Now this space has no barrier, so it allows very easy tumor extension and access to other extralaryngeal structures. This can also spread to the thyroid cartilage anteriorly and through the thyrohyoid membrane into the thyrohyoid space and the thyroid gland. Laterally, it can involve the paraglottic space. In a little bit, we'll discuss about pre-epiglottic space and paraglottic space boundaries because that is a very important delineation that you need to know about because these are the spaces that are involved in the spread of the carcinoma. So laterally, as it involves the paraglottic space, it can lead to vocal cord fixation and involvement of intrinsic laryngeal muscles. Posteriorly, it can extend to involve the arytenoid, posterior commissure, and hypopharynx, especially the piriform sinus. And inferiorly, the supraglottic CA can involve the glottis or the subglottis crossing the vocal cords. So this is about the local spread. Now, if supraglottis CA is actually very richly supplied by lymphatics, so it is very common to see a early and frequent lymph node metastasis in supraglottic CA. Commonly involved lymph nodes are the level 2, 3, 4, and sometimes it can also involve the retropharyngeal nodes. Now, bilateral lymph node is common due to a rich cross midline lymphatic drainage. Lastly is hematogenous spread, which is less common over here, but if it does happen in advanced stages, it can involve the lung, liver, and bone. So this is about the spread of supraglottic CA. Now let's talk about glottic carcinoma. Again, it will have local spread, lymphatic spread, and hematogenous spread. So first, let's talk about local spread. Now, superiorly, glottic carcinoma can spread into the supraglottis via the ventricle. Inferiorly, it can involve the subglottis and even the trachea. Laterally, it can involve the vocalis muscle causing vocal cord fixity. It can involve the paraglottic space also causing vocal cord fixity, and then it can go into the thyroid cartilage. It is important to know here the spread in the paraglottic space is limited by the conus elasticus medially and the perichondrium of the thyroid ala laterally. So further spread will occur either above or below or via the cricothyroid membrane. Posteriorly, the glottic CA can involve the arytenoid, the cricoarytenoid joint, and the posterior commissure. And anteriorly, it can involve the anterior commissure. Now, this is a very important route because the anterior commissure at this level, it has a very thin mucosa and it has a very minimal barrier. And here is when we find an early cartilage invasion happening if the anterior commissure gets involved. Now, say the anterior commissure has gotten involved, what other areas will it spread to from here? So, via the anterior commissure, it can reach the opposite vocal cord. It can reach the thyroid cartilage because of the Broyles ligament attachment. It can reach to the subglottis or the supraglottis, or it can penetrate the cricothyroid membrane and lead to an extralaryngeal spread. So these are the local spread pathways in a case of glottic carcinoma. Now coming to lymphatic spread, we already know that the glottis region actually has very few lymphatics. It is a watershed area, and that is the reason why nodal metastasis is not a common feature seen in cases of glottic CA, especially in the early stages. However, it can involve in later stages, and if it does involve, usually it is seen when the tumor has involved the anterior commissure, supraglottis, or the subglottis, or if it ends up crossing the paraglottic space. In this case, the levels that will be involved are level 2 to 4 when there is a supraglottic extension, and level 6 if there is a subglottic extension. And again, hematogenous spread is uncommon, and if it does happen, it will involve the lung, liver, and the bone. Last of all is our subglottic carcinoma, and how does it spread? So again, it will have local, lymphatic, and hematogenous spread. Locally, it can spread superiorly to involve the glottis, the true vocal cords, and the anterior commissure. Inferiorly, it can go into the upper trachea. Laterally, it can infiltrate through the conus elasticus to involve the paraglottic space and the thyroid cartilage. And posteriorly, it can involve the cricoid cartilage, the cricoarytenoid joint, leading to vocal cord fixation. Lymphatic spread, again, it has a better lymphatic drainage compared to the glottis, so early nodal metastasis can be seen over here. And in this case, the nodes most commonly involved are level 4, level 6, and occasionally level 7, which is the superior mediastinal nodes. Last of all is hematogenous spread. Again, that's the same for all of the larynx carcinoma. So these are all the spread patterns that you see in the spread of laryngeal carcinoma of different subsites. This is actually very important to know, and when you are able to describe it in terms of direction, specifically when you are asked a question in Viva, that'll definitely get you a lot of marks. Next, let's talk about what are some natural barriers for spread of carcinoma of larynx. This is again a very important Viva question that you are asked. And the answer for this is laryngeal cartilages, hyoepiglottic ligament, thyrohyoid membrane, quadrangular membrane, conus elasticus, anterior commissure, and cricothyroid membrane. I have separate videos on laryngeal anatomy where I discuss everything in details, the ligaments, the cartilages, the membranes. You should definitely check it out for more understanding of these structures. Next is now coming to the neck node involvement in carcinoma larynx. This is something I already mentioned as to which nodes get involved in which carcinoma. But just to summarize it and also look at what is the percentage of neck involvement in the different subsites. So in case of supraglottic carcinoma, there is a 30 to 50% chance of neck node involvement, and the common nodes are level 2, 3, and 4. In glottic carcinoma, neck node involvement is very rare. It is 1 to 4%. And the most common nodes involved are level 2 and 3 if it has spread to the supraglottis, and prelaryngeal node or the Delphian node if it has spread to subglottis. And subglottic CA, we see a 14% involvement of neck nodes. And this involves the level 4, level 6, and even level 7, which is the superior mediastinal nodes. Next, let's talk about a few anatomical things. First of all, is I mentioned Broyles ligament because that acts as a pathway of spread to the thyroid cartilage. Now, what is Broyles ligament? This in the image over here, you can see that this is the Broyles ligament that we see. This is a fibrous band, as you can see, in the anterior commissure, which extends from the vocal ligaments over here to the midline of the inner surface of the thyroid cartilage over here. This is 1 millimeter wide and 10 mm in length. And at this insertion, very important factor is that the thyroid cartilage is devoid of perichondrium. This is the reason why it facilitates an early cartilage invasion in case of glottic cancers. So this is the importance of Broyles ligament. So you definitely need to know what is Broyles ligament and where does it attach to and what is the clinical importance of it. Next, let's discuss the three different important spaces in the larynx anatomy. First is a pre-epiglottic space of Boyer. Now, in this case, you have to know what is the boundaries and the content of this space. So if you let's look at the image over here and we'll easily be able to determine what are the boundaries. So this yellow area that you're seeing over here, this is a pre-epiglottic space. So if you look anteriorly, you'll be seeing that we have the thyrohyoid ligament, we have the hyoid bone, and we have the thyroid upper part of the thyroid cartilage. These three together form the anterior boundary of preepiglottic space. Now, if you look posteriorly, we have the infrahyoid epiglottis and the quadrilateral membrane. Next, if you look superiorly, we have the hyoepiglottic ligament, which is connecting the epiglottis to the hyoid bone. And laterally, which is not seen here, it is continuous with the second important space, which is the paraglottic space. And this acts as one of the pathways of spread. If the pre-epiglottic space gets involved, very easily it can involve the paraglottic space as well. And as we have discussed before, if the paraglottic space gets involved, it will lead to vocal cord fixation. And also, this is also the pathway through which a transglottic tumor develops. And the content of preepiglottic space is fat, areolar tissue, and lymphatics. Next, let's talk about the paraglottic space, also known as the Tucker's space. Now, the boundaries over here is laterally, it has the thyroid cartilage and the thyrohyoid membrane. Medially, from above downwards, it is bounded by the quadrangular membrane, laryngeal ventricle, and the conus elasticus. And posteriorly, it is bound by the pyriform fossa mucosa. Now, the paraglottic space, as I just mentioned, it communicates with the pre-epiglottic space anterosuperiorly. And the last space which is important is the Rinke space. Now, the Rinke space, if you look at the image over here, this is our Rinke space. This is a potential submucosal space which lies under the epithelium of the vocal cord, and it has very scanty subepithelial connective tissue. Now let's talk about boundaries. Now, it is bounded above and below by the superior and the inferior arcuate line, anteriorly by the anterior commissure, posteriorly by the vocal process of the arytenoids, medially by the free border of vocal cord, and laterally by the vocalus. Now, it is important to know that in different position, it has different boundaries. So, when the vocal folds are adducted and they are meeting each other during the time of phonation, in that case, it has a medial boundary and a lateral boundary. In that case, it will not have a superior and an inferior boundary. But when the vocal folds are not in opposition to each other and in inspiration it is on abduction, in that case we have a superior boundary and an inferior boundary, but we do not have a medial and a lateral boundary. So this is about all the three important spaces of larynx. Now let's talk about the staging. In our case we have found that it is a case of T1A N0 MX and it falls under stage 1. Now, this is the TNM staging for glottic carcinoma. We have a different staging. The T staging is different in case of supraglottic and the subglottic carcinoma. So first, let's look at T1. T1 is when the tumor has been limited to vocal cord. It can involve the anterior or the posterior commissure, but important to know that it has normal mobility. T1A is further divided into T1A, where it is limited to just one vocal cord, and T1B if the tumor involves both vocal cord. So this is T1 where we have the tumor limited only to the vocal cord with a normal mobility. Next is T2. T2 is when it is going beyond the glottis to either extend to involve the supraglottis and or the subglottis. And important to know here is there is an impaired vocal cord mobility over here. Now, T3 is again a tumor which is limited to the larynx, but here we'll find vocal cord fixation and or it will invade some structures like the paraglottic space and or minor thyroid cartilage erosion. So this is T3. T3 is when it has started spreading more and it involves the paraglottic space, or we have vocal cord fixation, or we have cartilage erosion. Next is T4. T4 is divided into T4A and T4B. Now, T4A is when the tumor has invaded through the thyroid cartilage or it has invaded extralaryngeal tissue, which can be trachea, soft tissues of the neck like the deep muscles of the tongue like genioglossus, hyoglossus, palatoglossus, and styloglossus, strap muscles, and thyroid and esophagus. Whereas T4B is when it is involving one of the three structures, which are the prevertebral space, mediastinal structures, or the carotid artery. This is the T staging in case of glottic carcinoma. Now, the N staging and the M staging remains constant in this case for all the larynxia. NX when the regional lymph nodes have not been assessed. N0 when we do not have any regional lymph node mets. N1 is when it involves single ipsilateral lymph node, 3 centimeter or less in greatest dimension without any extranodal extension. So it is single ipsilateral 3 centimeter or less. Next is N2, which we can further divide into N2A, 2B, and 2C. So 2A is when there is a metastasis in single ipsilateral lymph node, but here it is more than 3 centimeter, but not more than 6 centimeter in greatest dimension, again without any extranodal extension. N2B is when there is multiple ipsilateral lymph node, but none of them are more than 6 centimeter, again without extranodal extension. N2C is when there is bilateral or contralateral lymph nodes, not more than 6 centimeter in greatest dimension, without an extranodal extension. Then we come to N3. So the newest classification, the newest staging is divided into N3A and N3B. In N3A, we see a metastasis which is more than 6 centimeter. So in N2, we saw that the size is not more than 6 centimeter. In N3A, we find the size is more than 6 centimeter, but there is no extranodal extension. But N3B is characterized by, it can be single node or it can be multiple node. It can be any size, but we'll see a clinical extranodal extension. So let's summarize this again. So N1 is when there is single ipsilateral less than 3 centimeter. N2A is single ipsilateral more than 3 but less than 6 centimeter. N2B is multiple ipsilateral less than 6. N2C is bilateral or contralateral less than 6. N3A is more than 6 centimeter but without any extranodal extension. And if there is any extranodal extension, it automatically becomes N3B. So this is how you can easily remember the N staging. Last of all is the M staging, which is MX is when you have not assessed, M0 is no distant metastasis, and M1 is distant metastasis. So this brings us to the staging part. So stage 0 is when it is tumor in situ TIS and 0 M0. Stage 1 is T1 N0 M0. Stage 2 is T2 N0 M0. Stage 3 is T1 T2 N1 M0. T3 N0 N1 MO. So it is important to see the way you can remember is whenever you have a case of T3, it automatically doesn't matter what the N status is, it becomes automatically stage 3 minimum. And then depending on the end stage, you decide whether it is stage 3 or it is stage 4A. Second thing to remember here is this is actually a very complicated thing to remember, but I'm just giving you a few tips to remember certain levels. So, whenever you find N2 involvement, it becomes the minimum stage is stage 4A. And if there is N3 involvement, the minimum stage is stage 4B. And if you find any metastasis, it automatically becomes the last stage, which is stage 4C. So these are 4 points that you can remember that will easily take you to your staging. Next, let's talk about how are we going to manage the case. Now, management will always be of two parts. First is investigation and then is treatment. So definitely never say that, whenever somebody asks you what is the management of the case in your exams, don't directly jump to treatment, because we do have we think we know the answer and we directly jump to treatment, but that's actually wrong. Management will definitely always involve first investigation and then treatment. First, let's look at the investigations. What are the investigations that we'll be doing? There's routine blood investigations that you'll be doing for surgical profile. Second is sputum for AFP, culture sensitivity, and gram stain to rule out any case of tuberculosis and other infections. Next, we should do a video laryngoscopy. This is done to visualize the extent of growth. This is must. We will also perform a stroboscopy. Now, stroboscopy is usually helpful in case of early glottic lesions. What does stroboscopy do? It tries to evaluate the mucosal wave pattern and the vocal fold vibration. And this can help you in detecting very early glottic cancers. And this will help you in distinguishing between benign and malignant vocal fold lesion based on the absence of mucosal wave and irregular vibration. So in carcinoma, the finding that we see is the mucosal wave is reduced or absent over the involved area. This is a red flag sign for malignancy. Stroboscopy is also useful for assessing the phonatory function, which will help you in further treatment planning and post-treatment follow-up. And this will also provide you with a video documentation of the vocal cord function at the time before any treatment has been given. And this will be helpful for monitoring the progression of the disease and response to treatment. So these are all the reasons why stroboscopy should be done. And this is very helpful in early detection of glottic cancer. Next, the gold standard investigation that you must do is a direct laryngoscopy and biopsy. And there are three purposes for this. First, to perform a biopsy of the lesion. Second, to check for the extent of the tumor. What is the superior extent? What is the inferior extent? What are all the structures involved? And third, to check for the mobility of the cord. This will help you in decide what is the staging of the disease, and that itself will help you in deciding what is the treatment plan, what are the treatment options you have, and what is the treatment plan you would take. Next, coming to neck area, we'll perform an X-ray neck lateral view. This will help you in seeing the tracheal lumen and the inferior extent of the growth. However, a better investigation to perform here would be a CECT of the neck. It is important to remember here that you should perform the CECT of the neck before you perform the biopsy, because after you perform the biopsy, there will be some inflammation in the area. So then, if you perform CECT neck after the biopsy, it will actually not lead to the right findings, because the inflammation will kind of interfere with the proper findings that your patient has. So it is very important to perform CECT neck before you perform a direct laryngoscopy and biopsy. And what are the things that you will be noticing over here in the CECT neck? You'll check for cartilage invasion. You'll check for any space involvement like the pre-epiglottic space and the paraglottic space. You'll check the nodal status. It'll help you in tumor bulk measurement, subglottic extension, tracheal involvement, and any extralaryngeal extension. And all of this will help you in deciding what is the stage of your disease and what are your treatment options. Lastly, we should also perform an X-ray chest or a CT chest for various reasons. The first reason being this will act as a pilot film, which will be a reference for your follow-up later on. You can check for mediastinal widening if there's any secondaries in chest, because lung is one of the common sites for metastasis in this case. You can also check for any second primaries. It'll help you in cardiac evaluation. It can help you in ruling out aspiration pneumonitis. If any other differentials are being considered to find any tuberculosis, cavity, or fungal balls, and to check for mediastinal extension or nodes. So this is why you should perform a CT chest or an X-ray chest. These are all the investigations you should perform in your case. Now let's talk about what are the features of malignant lymph node. Now this is again a very important Viva question, and it is very important to remember all of the points that I have mentioned over here. First of all is the size. Usually it is more than 1 centimeter in size. Specifically in case of jugulodigastric node, it is more than 1.5 centimeter in size. Then coming to shape, it is usually spherical, where the long axis is equal to the short axis. Third is it has an eccentric thick cortex more than 3 mm. Next important feature is a loss of the fatty hilum. It will have irregular or ill-defined margins. Central necrosis is very common. Calcification may be seen. Peripheral or mixed vascularity on Doppler USG. Extranodal spread. This is again a very important feature. Extranodal spread is present where there can be fat stranding, irregular capsule, or infiltration of the adjacent structures. Last of all is a matting of nodes. So these are all the features that you'll see in a case of malignant lymph node radiologically. Now let's talk about what is the treatment that we will be giving to our patient. So here we will be doing our patient will be receiving radiotherapy. Now, how did we come to that conclusion? So before that, we need to know what are the treatment options in different T staging in case of glottic CA. So first, let's talk about T1. So our case falls under T1A. So T1A is when there is one vocal cord involvement, and T1B is when there is both vocal cord involvement. So in case of T1 staging, we have 3 options. Out of them, the first one, radiotherapy, is usually the most common one because it has very high cure rate and excellent voice outcomes. Second is we can also do a transoral laser microsurgery because this is a very voice sparing surgery and it can be done on an outpatient basis, and it also has equivalent oncologic outcomes. Third option is open cordectomy, which is usually less preferred due to the invasiveness of the surgery. So these are the 3 options in case of T1 tumors. Now, in this case, how do we decide? We'll discuss more in details in a little bit. But voice outcomes and patient choice often help you in deciding what is the modality of treatment you're choosing. And because in T1 stage, usually early node metastasis is not seen in glottic carcinoma, so neck dissection is not required over here. Next, coming to T2. T2 is when the supraglottis or the subglottis has been involved and there is an impaired vocal cord mobility. Here we have 4 treatment options. The most common one being radiotherapy. This is preferred because of the function preservation. Second is a transoral laser microsurgery or a partial laryngectomy for well-selected cases. Third is open supracricoid laryngectomy. This is considered if the tumor spread is more extensive. And last is a combination of radio and chemotherapy. If this is only when adverse features are present and for high risk cases. But the most common treatment that is given is usually radiotherapy. Now, neck nodes again is not very usually involved in T2 glottic carcinoma. So, elective neck treatment, elective neck dissection is not required over here. And it is very important to monitor the vocal cord mobility over here because if there is a fixed vocal cord, in that case, it implies that it is T3. So, then it will end up in upstaging the disease and your treatment plan and treatment options will change. Next is T3 staging. Now, T3 staging is when we have vocal cord fixation, where there is an invasion of the paraglottic space or a thyroid cartilage erosion. So, what are our options here? The first option is a organ preservation protocol, which is usually followed, where we give radiotherapy and concurrent chemotherapy. This is the standard for preserving the function of larynx. Second is total laryngectomy with or without neck dissection. But this is considered only if the patient has poor laryngeal function or they are poor radiotherapy candidates. Last of all is radiotherapy alone, which is less preferred unless there are comorbidities present, which prevent you from performing surgery for the patient or providing chemotherapy. So these are our three options in T3, but usually we try to follow the organ preservation protocol. But in case the function of the larynx has been lost, in that case, we go for surgery where we perform a total laryngectomy with or without neck dissection. At this staging, it is important to do a bilateral neck evaluation to decide whether you want to perform a neck dissection or not, because the chances of nodal mets in this stage is higher than in the early cases. Last of all is T4. In T4, the option over here is a total laryngectomy with a bilateral neck dissection, which is our primary treatment, followed by a post-operative radiotherapy with or without chemotherapy. This will be decided based on if there is any adverse histological features. Second option is a non-surgical option where you just give chemoradiation. This is given in patients who are unwilling for surgery or unfit for surgery. However, this is a less preferred option. We'll definitely try to go for total laryngectomy over here, more preferably. So in T4A, T4A is moderately advanced and often it is surgically resectable, whereas T4B is very advanced and it may be unresectable. And in that case, we should just give palliative chemoradiation. So this is all our treatment planning for all the different T stages in a glottic carcinoma and why we should take, which option is usually preferred and why. Now, this is not a treatment plan. This algorithm is not something that is just blindly followed for every patient. You should definitely be making your specific decision based on the specific case that you have. So that leads us to the question of what are the factors which will help you in deciding the treatment choice. So we have 3 types of factors: patient factors, tumor factors, and institutional factors. All of these matter and all of these will help you in deciding which treatment plan to follow. First, let's talk about the patient factors. The first factor here is age. If it is a younger patient, we'll definitely be preferring surgery so as to avoid any long-term radiotherapy side effects. But in cases of older patients or those who are unfit for surgery, in that case, we'll direct the treatment towards radiotherapy. Second factor is comorbidities. If there are significant comorbidities present, then usually we prefer to do a surgery rather than radiotherapy so as to avoid the systemic side effects of radiotherapy. Third is what is the profession of the patient? What is their voice demand? So, in case of professional voice users like in singers, teachers, we usually prefer radiotherapy, which is our case over here. Our patient here is a teacher by profession. That is why we need to preserve their voice as much as we can. So here we'll prefer radiotherapy. Surgery, what does is it can impact the mucosal wave pattern of the vocal cord, and it can impact the voice. Even if you perform a transoral laser microsurgery, it will end up impacting the voice, because in these professions, the voice is very important. Whereas, say your patient is a daily wage laborer. In that case, radiotherapy will not be a preferable option. That's because daily wage laborer, they earn on a daily basis. So you cannot give them a treatment option that will involve them coming to you multiple times and missing their work. That's not how their family will run. In that case, we'll perform surgery because it is more of a one day thing and less of follow up. In radiotherapy, you'll need multiple sessions for 6 to 7 weeks that will impact their livelihood. And also, in daily wage laborer, voice quality is not a huge concern as compared to other professional voice users. And last of all is also patient's preference, because some patients may prefer a one-time surgical procedure, some patients may prefer radiotherapy. So that's also a factor that comes into play. Next, let's talk about the tumor factors. Now, first tumor factor is the stage of the disease, the T staging more importantly. So, in case of T1A and T1B tumors, they can either undergo a transoral laser microsurgery or radiotherapy. But when it comes to T2 tumors with an impaired mobility of the vocal cord, they are better managed with radiotherapy. Next is the location of the tumor. If there has been an anterior commissure involvement, it becomes a challenge to perform surgery because of its poor exposure and high recurrence risk. Third is extent of lesion. So, if there's a large tumor or poorly accessible tumor, then it is better managed with radiotherapy. Whereas very superficial lesions, which are confined to maybe one vocal cord or even two vocal cord, they are ideal for transoral laser microsurgery. And last is the histology and grade of the tumor, which you'll find when you perform a biopsy. If it is a high grade tumor or with very poor margins after surgery, then in that case, they may require an adjuvant radiotherapy. Last of all are the institutional factors. Now, this is also very important because you have to know what your institution provides. The first important thing is whether you have equipments for the plan that you are making. So, transoral laser microsurgery requires access to very specialized tools like an operating microscope, a CO2 laser, micro instruments, etc. If your institution has it, then definitely it is an option for your patient. Second is surgical expertise. Availability of skilled microlaryngeal surgeons experienced in transoral laser microsurgery is very important for you to give that treatment option to your patient. Third is radiotherapy facilities. So, high quality radiotherapy with IMRT or IGRT facilities, they ensure a better outcome and voice preservation. And last of all is what are the follow up protocols. So, transoral laser microsurgery requires a meticulous follow up with endoscopic surveillance for checking for recurrence of the disease. So these are all the factors that will help you in deciding the treatment outcome, what plan would choose for your specific patient. It's tailor made for every patient, and it's not a direct plan that you follow blindly for just because a person is in T1 stage, you'll follow just one plan. That's not how it works. You'll definitely have to cater to your patient's needs. Now let's talk about, okay, we have talked that for our patient, we want to give them radiotherapy. Now, there are certain things you need to know here. The first question is, what is the dose that is given? So our dose over here is 60 to 70 gray at 2 gray per day for 5 days a week over a period of 6 to 7 weeks. So a total of 30 to 35 fractions is given. An important conversion over here that you need to know is 1 gray is equal to 100 rads. Sometime your examiner may ask you a trick question and ask you how many rads are given. So you may get confused and be like, okay, I don't know rads. So this is how you can convert a gray into rads. Next, let's talk about what are the contraindications of radiotherapy. This is contraindicated in case of a residual tumor, in case of recurrent tumor, if there is a cartilage invasion, fixed vocal cord, or fixed hemilarynx, because all of these cases suggest advanced disease. In that case, poorer radiotherapy outcome. If there is a space involvement of the P epiglottic space and paraglottic space, and there is perichondritis, skin involvement, in advanced T3, T4 tumors because they are less responsive to just radiotherapy alone. It has to be combined with surgery. Next, if there is a history of previous radiation to the neck, because in that case, there is a risk of severe tissue necrosis and complications due to cumulative dose that has been given to the patient. Next, if the patient has uncontrolled connective tissue disorders like scleroderma, lupus, they will be at a higher risk of radiation induced fibrosis and poor healing. Next is a poor general health or performance status of the patient where they'll not be able to tolerate the side effects of radiotherapy. And lastly is severe aspiration or airway obstruction because these cases will need surgery first to protect the airway. So these are all the contraindications of radiotherapy. Next, let's talk about what are the advantages of radiotherapy. And we'll also talk about what are the disadvantages. So, advantages, the first of all advantage is voice preservation. So, radiotherapy helps in preserving the structure and function of the vocal cords better than surgery in early T1, T2 cases. Second is radiotherapy can help you in downstaging your disease. An inoperable tumor can actually become operable with the help of radiotherapy. Next is it is a non-invasive treatment where we do not need to give any incision, we do not need to give any general anesthesia to the patient. Fourth is it is very suitable for elderly and comorbid patients who will probably not tolerate surgery well. It has high local control rates. In T1 glottic cancer, 5-year local control rates is 85 to 95%, and in T2 it is 70 to 85%. And survival outcomes for radiotherapy are actually comparable to that of surgery. Next advantage is that it can be performed on an outpatient basis. So this will avoid any hospital admission. This also does not require tracheostomy. So that's also an advantage over here. Next is it preserves the laryngeal framework, which is very important because that keeps your options open for other future treatment plans in case the patient, in case we see a recurrence in your patient. So surgical salvage option is still possible with radiotherapy. And last of all, it has good cosmetic and functional outcomes because there is no surgical scar or disfigurement of the patient, which is very important for patients. And a better swallowing and airway protection function is preserved in case of radiotherapy. So these are all the advantages of radiotherapy. Next, let's talk about what are the disadvantages of radiotherapy. So the disadvantage is it can have a prolonged treatment duration. As we discussed, the treatment goes on for about 6 to 7 weeks, where they have to come for 5 days a week, which is a very long period of time. Second is there is a delayed assessment of treatment response. So this is not like surgery where you can just where you have completely removed the tumor. So in this case, the tumor regression may take weeks to months to happen after the radiation is over. So it is very difficult to assess early whether the tumor has fully responded or not. Third is there's no histopathological confirmation. So in surgery, you remove the tumor completely. So you have a specimen. So you can confirm the tumor margins and the exact histology. But this is not possible in case of radiotherapy. Next is a risk of radiation induced side effects. That's something we'll discuss next. Last of all is there is limited retreatment options. So once radiotherapy has already been given, you cannot, it reduces the possibility of giving radiotherapy again in the same area. So in this case, if recurrence does happen, in that case, salvage surgery will be your only option and it will become slightly more technically difficult because of the tissue fibrosis as a result of radiotherapy. So these are all the disadvantages of radiotherapy. Now let's discuss what are the complications of radiotherapy. So we have acute complications and late complications. So in acute complications, you can have mucositis where there's basically inflammation of the mucosa. So commonly patient will complain of painful swallowing or there's a increased risk of superadded infections. Then there can be radiation dermatitis where we see erythema, deformation of the skin, hyperpigmentation of the neck skin in the radiation field. Next, the patient can complain of dysphagia or dinophagia. There can be laryngeal edema, which can end up in worsening the voice and the airway. Xerostomia, which occurs because of salivary gland involvement, which in turn can affect the oral hygiene of the patient and speech. And there can be a disturbance of taste, dysgeusia, but this is usually a temporary condition. Next is what are the late complications that we see? This can actually take months to years to develop, and this can be long lasting or even permanent. So, first is chondronecrosis, where we see a necrosis of the laryngeal cartilages due to vascular compromise. This can lead to fistula development, airway obstruction, or even require laryngectomy. Second is fibrosis and stenosis of the soft tissues of the neck. It can actually lead to laryngeal stenosis, and then now that itself now present with a second problem of dyspnea or stridor. There can be voice changes like permanent hoarseness or weak voice due to tissue fibrosis and scarring. There can be trismus because of fibrosis of masticatory muscles or temporomandibular joint involvement. Again, a very important late complication is hypothyroidism. So it is very important to keep on checking the thyroid parameters because of incidental thyroid gland radiation. This can actually take months to years after treatment to appear. Next is a risk of aspiration because of impaired laryngeal sensation or poor glottic closure. Osteoradionecrosis, which is very rare, it can affect the mandible more commonly than the maxilla. And last of all is the development of second primary malignancies. This is also a very important complication to remember in case of radiotherapy. So these are all the complications of radiotherapy. Now let's talk about what are radiosensitizers. Now, radiosensitizers are these drugs or substances which enhance the efficacy of the radiation therapy that you're giving by increasing the tumor cell kill without significantly affecting the normal tissues. Now, the usual mechanism of action here is that they inhibit the DNA repair after radiation induced damage. They increase the production of free radicals in the tumor cells and they improve the oxygenation. So, hypoxic cells are usually more resistant. So, improved oxygenation will actually make the patient more radiosensitive. What are some examples of radiosensitizers? They are metronidazole, hyperbaric oxygen therapy, and chemotherapy drugs like cisplatin, 5-fluorouracil, carboplatin, and cetuximab. Now, there are two terms you need to know, which is IMRT and IGRT. So, what is IMRT? IMRT is intensity modulated radiotherapy. What does that mean? So, this is a type of external beam radiation therapy which delivers highly conformal modulated doses of radiation to a tumor while trying to minimize the exposure to the surrounding healthy tissue. This is a very precise form of radiation that is used in the treatment of various carcinoma. Now, what is the advantage of using IMRT? First of all, is it because it has more focused doses, it is actually having better tumor control. Secondly, because they are trying to avoid minimize the exposure to the surrounding healthy tissues, so you will have lesser side effects. Third is you'll have better preservation of voice and swallowing function. And therefore, this becomes a very important part of organ preservation protocols. Next is IGRT. What is IGRT? Now, this is image guided radiotherapy. Here, we use frequent imaging during the course of the radiation treatment so as to improve the precision and accuracy of the treatment delivery. Now, this helps us in conforming the radiation dose more precisely to the 3D shape of the tumor by modulating and controlling the intensity of the radiation beam in multiple small volumes. So, these are two definitions, and just a little bit understanding about this is very important in your post graduation. Okay, last of all, let's discuss a little bit about our third option. You remember we spoke about cordectomy being an option also in the T1 stage. Now, what is the classification that we know here? So, there is a European Laryngological Society classification that we have for cordectomy for glottic CA. So, a type 1 is subepithelial cordectomy. If you see in the image here, that it involves resection of the vocal fold epithelium only, passing through the superficial layer of the lamina propria. Now, type 2 is a subligamental cordectomy. If you see in the image over here, it involves the resection of not only the epithelium, but also the Rinke space as well as the vocal ligament. Next is type 3, which is a transmuscular cordectomy. Here, the resection is done up to the vocalis muscle. Then is type 4, which is a total cordectomy. Here we perform a resection of the cord which extends from the vocal process to the anterior commissure, and the depth of the surgical margin will reach or include the internal perichondrium of the thyroid ala. So you can see the extent over here. Next is type 5, which is extended total chordectomy, and type 5 is further divided into four types. Type 5A is when the resection includes the contralateral vocal cord as well as the anterior commissure. Type 5B is when the resection involves the arytenoids. Type 5C is when it involves the subglottic region. Type 5D is when it involves the ventricles and the false cords. So this is the type 5. Last of all is type 6, which is anterior commissurectomy. Here if you see in the image here, you can see clearly, here we perform a resection of the anterior commissure with bilateral anterior chordectomy. This may include the subglottic mucosa and the cricothyroid membrane as well. This is a very, again, a common question, or even you can get it in your short notes. What is the ELS classification for chordectomy in a case of glottic carcinoma? Okay, coming to our last portion. Let's discuss what are the prognostic factors. How do we decide the prognosis of the disease? So, again, here we have tumor related prognostic factors and patient related prognostic factors and treatment related prognostic factors. So, first, let's start with tumor related one. The most important prognostic factor is the T stage of the disease. Early stages T1, T2 have better prognosis, whereas advanced stages they have poorer prognosis. Next is end stage. So, presence of end stage definitely worsens prognosis. So, N0 will definitely have better survival. Next is what is a subsite that is involved. Now, glottic cancer, because it's also the most common one that is involved and it presents with hoarseness of voice, it is early detection, because of which it has the best prognosis, and also because of the factor that it has the least lymphatic spread. Whereas supraglottic CA is actually having rich lymphatics and they have higher rate of nodal metastasis, making the prognosis poorer. And the poorest prognosis is that of the subglottic cancer because they are rarer cancers which is often diagnosed very late. So in that case, they end up having poorer prognosis. Next is vocal fold mobility. If there is a mobile vocal cord, it has better prognosis, and fixed vocal cord will have poorer prognosis because it suggests deeper infiltration. Next is histological grade. If it is a well differentiated squamous cell carcinoma, it has a better outcome. If it is poorly differentiated, it is more aggressive and worse outcome. If cartilage invasion is present, in that case, it has a poorer prognosis because it indicates the presence of advanced stage T4. And extralaryngeal spread is also a poor prognostic factor. So these are all the tumor factors. Now let's talk about what are the patient related prognostic factors. So first of all, age. Younger patients obviously will generally tolerate the treatment better, whereas elderly who may have comorbidities, they will affect their prognosis as well. Second is the performance status, the Karnofsky score of the patient. If there is a poor performance status, it means a poorer outcome and tolerance to the treatment. Presence of comorbidities will also be a poorer prognostic factor, and continued tobacco or alcohol use. This will also be a poor prognostic factor because it increases the risk of recurrence and second primaries. Last of all are the treatment related prognostic factors. So, first is the modality that you have used. Organ preservation protocols, that is chemoradiation, they usually have good results in early stages. Surgery may be needed in advanced stages. Second is what is the response to initial therapy. So, a complete response usually has a better prognosis, whereas ones who come with residual or recurrent disease, they have a worse prognosis. Last factor is treatment delays or any interruption in the treatment that will compromise the tumor control and survival. So, these are all the prognostic factors, your tumor factors, your patient factors, and treatment factors. Last question for today's discussion is what are the survival rates of laryngeal carcinoma? So, the 5-year survival rate of a T1 stage is 85 to 95%, T2 stage is 70 to 85%, T3 is 50 to 65%, and T4 is 30 to 40%. So, that completes our case discussion on a case of glottic carcinoma. If you have any further questions, please note them down in the comment section and I'll get back to you on this.